Gina Hernandez-Boussard is a very special person. I can tell you that. This is her second visit, and it's been a delight to get to know her. You know, it's very rare that you find somebody who has training in the very basic mechanistic stuff, all the way through clinical research into outcomes research and epidemiology, but this person hasn't. And although she's an associate professor right now, she has 121 research publications, which like you kind of like scratch your head and say, what's this all about? And what it's all about is that she had a career, you know, that involved computational biology and epidemiology as a staff scientist at Stanford before she really started up on the academic track. So she's got all this wealth of experience. She was in the Department of Surgery for 10 years and studied health outcomes. I think you're going to learn about some of that, so I won't preempt that. You know, and if you go back, she got her PhD after, she's a California lady. So, you know, we're trying to get her here, so we know that's a little hard. You know, she got her 2 bachelors, one in psychology and one in biology at Irvine. And then she went off to Yale, and where she got an MPH in epidemiology. And then she moved to France. Got married, moved to France. Yeah,
yes.
You know, no particular order there. Don't want to get into that. And studied at the University of Lyon. You know, probably the best food city around in France, at least. Got a PhD there in computational biology. And I was asking her about that. I said, gee, you know, Tina, did you have to take your classes in French? She said, no, but she had to defend her PhD thesis in French. That sounds interesting. But anyway, she's she's now and also received a master's degree in health services research at Stanford in 2013. She's currently a professor primary with our good friend Mark Mewson at Stanford Medical Informatics in the Department of Internal Medicine. She also has appointments in biomedical data science with Carlos Bustamante, and she still maintains her faculty membership in the Department of Surgery, where she had been for 10 years, all at Stanford University Medical Center. We're delighted to actually have you. You've won many awards. You're an innovator. You're a fun person to be around. And today, you know, we're going to hear about high-volume digital biomedical data, promise and potential to improve healthcare quality. And welcome back, Tina. It's delightful
Thank you so much.
Thank you.
Thank you, Brian, for having me here and giving me this opportunity to share my research. I have been here before, so I'm going to try and show you another aspect of the research we're doing. It is, as Brian mentioned, I'm going to talk to you about some of the high volume data that we have in healthcare right now. And you know, I've had the opportunity to meet with some of you both today and in past visits, and it's so exciting to be here and share my research with you. I feel that I can learn a lot from what you're doing here within the department, and I also feel that I have a lot that I can help contribute to what you are currently working on. So digitalization of health information, it's everywhere. It's all around us. We hear it in the media. We hear it all over. We're kind of bombarded by all this information. And when we think about where we've come over the past, you know, several years, decades, you know, when we first started looking at the digitalization of healthcare data, it was all about memory and storage. You know, we didn't have enough memory to store our gene expression data. We didn't have enough memory to store some of the sequencing data we had. And once we got past the memory, it was, well, if only we had electronic data, electronic healthcare data. And so over the past, you know, decade and recent years, we now have electronic healthcare record data everywhere. I think one of your former colleagues, Julia Adler-Milstein, published that, you know, over 90% of US hospitals now have a digitalized form of their healthcare record. So we have all this data, but now what do we do with it? How do we pull it together? How do we use it to improve healthcare, to improve value? How do we bring it to the point of care? And that's something that I'm really interested in. And I want to help, you know, I want to share with you today some of the ways we're thinking about using this data. Because right now, you know, although we have all this data, there's a lot of questions regarding the value and reproducibility of this big data research. I don't have to tell you about healthcare costs. We've all heard it. You know, the US, it's estimated that 1/3 of the healthcare dollars spent in the US are wasted. You know, we have 4 times the average cost per patient than any other developed country. And what do we do with this information? We're collecting this information on individuals. Somebody comes into the ER room. They have, chest pain. We're performing tests. We're gathering data. We have all of these visual radiology images. And we take all this data, and then it gets stored, and it's never reused. We never look back on it to see, how can we learn from this experience? How can we take this information, all of this data we've collected on this patient, to think about how we can do better on the next patient? How can we use this information, gather this information to improve how we think about this care? There's a reproducibility crisis, and I talked to some of you about this today. Both basic and preclinical research in genomics and drug discovery, there's a huge talk right now in the literature that a lot of this data is non-reproducible. It's due to small sample sizes, small effect sizes. We can't reproduce something that's been published in the literature. And this is only things that have a positive effect. I mean, there's a whole nother source of data that have produced negative results that we don't even know about. So a lot of waste on resources, reusing data, trying to reproduce information that we're not able to reproduce. There's the disease burden research match. And so if you think about where all of our healthcare dollars go in the US, this is a nice graph that I like from PLOS One from John Ioannidis. You can see the blue lines are disease burden, and I'm not sure if you can read that very well. Number one disease burden, infectious disease. The red bars are where we spend our money in the US. So our money's going to cancer care, our money's going to endocrine disorders. So there's a big gap between disease burden and where we spend our research. However, it's these people with infectious disease, diabetes, these other things that are coming to the healthcare system all the time. We collect information on these patients. So how do we use this information? Oops, sorry. And when we talk about precision medicine, another aspect of it is social inequality. So we can talk about precision medicine. We usually talk about the biological aspect of precision medicine. We talk about finding that gene, finding that SNP that's going to account for the disease burden or the risk factors for disease in a particular population. But how does that translate to the population level? How do we use that information more, instead of for one individual patient, but more for the way we take care of hundreds of patients? So I like to think of precision medicine, there's two ways, and I learned today that you guys think about it in 2 ways too. You have the biology and sort of the genomics of medicine, and then you have the top half of sort of the precision medicine for the way we treat a patient. So for the biology, we're looking at genes, sequences, genomes, and we're trying to identify patterns that can be identified as risk factors for diseases, for onset of disease. But on the flip side, we have a lot of information on patients and how we treat patients, what works for patients, how patients respond to treatment. And that's also another piece of big data that we don't utilize enough, that we don't integrate enough into our healthcare system. So in our research, we talk a lot about high volume data. So from the person level, what are we talking about when we talk about high volume data? And how can we bring this data together to start thinking about precision in the way we practice medicine and taking this information on how we treat a patient to a personalized level? Well, we have the information on the genome and the biome, and all different types of omes, right? We have the exomes, we have the genomes, we have all different types of information where we have millions of variants on a few thousand patients, right? So think about that information, and we have so much information on the genome and the variants of this information, but how many people have been sequenced? And how diverse is that population that's been sequenced? Who has access to getting their data sequenced? It's not the entire population. On the other hand, we have our electronic medical records. So as we said, now we have hospitals all across the US that now have digital health information about their medical care, but who's in these systems? These are patients who are sick, patients who are sicker, and you also have the sickest patients coming in, right? Who do we have the most data on? The most represented person in the electronic medical record are the sickest patients. So when you think about developing your predictive models and looking at what's predictive of disease, what are these risk factors, what's your control population when you're looking only at the electronic medical record? So we have a lot of sort of bias in that information being collected. What about the wearables? We're starting to get a lot of big data on wearable devices. Many of you know who Mike Snyder is at Stanford. He wears 5 or 6 of these Fitbits, Google Watches, and he walks around with them. He's very proud of them too. And they're each measuring something different, but they can each give him a different measure for how many steps he's taking. So he's not taking a different number of steps, but the variability between these devices is enormous. And so how do we deal with all this information that the patient is generating? How do we incorporate this into our healthcare record and think about, how is this contributing to burden of disease? What about the environment? So we have a lot of information from geocodes. So in our healthcare record, each patient has a patient zip code. So you can get a lot of information from that patient zip code. You can look at air pollutants. You can look at violence in the area. They now have information on how many healthy markets are within a 1-mile radius of a certain geographic area. That's interesting information when you're thinking of looking at burden of disease, risk factors, etc. What about social determinants of health? We've heard a lot of talk about social determinants of health lately. And in fact, the Institute of Medicine published in, I believe it was 2016, there's 16 social determinants of health that should be regularly collected in any healthcare record. This included things such as financial instability, physical abuse in the home, smoking status, etc. So a lot of information a lot of talk has been around social determinants of health and how do we integrate this into our healthcare record and how do we integrate this into our treatment. And finally, what about patient values, patient-centered outcomes, quality of life information, things that really matter to the patient. So some of the work we look at is like guidelines and how guidelines are followed or not followed. What if the guideline says, a patient is supposed to have treatment X within 6 months of diagnosis, and the patient refuses that treatment? The patient doesn't want that treatment. How do you account for that when you're looking at these data? How can we say, is it the physician's fault that they didn't do the procedure when the patient didn't want it? So how do we start thinking about incorporating all this information into the healthcare system? And I love this chart. This is a chart from Kaiser Permanente. Looking at the health and well-being of an individual, and they've estimated different risk factors for disease. They say genomics accounts for about 30% of the health and well-being of an individual. Individual behavior, so social determinants of health, 40%. Social and environmental factors, 20%, and the healthcare system, 10%. So we've been focusing mainly on the genomics aspect, and now more recently on the healthcare aspect. So that's about 40% of factors contributing to the health and well-being of an individual. So there's so much more information that is out there that's available that can be integrated into the way we analyze data, the way we're developing models to predict this information. So let's talk about the data that's available. And data is really sparse when you think about these individual buckets of data. For electronic healthcare records, as I mentioned, you have people who come in when they're sick. You have maybe somebody who comes in once and then you don't see them for another 10 years. We have really sparse data in our medical records. Claims data is another piece of data. Claims data is very interesting, and I know that some of you have used a lot of claims data. A lot of people disregard claims data, but it's a really good source of information. You can get information on utilization. You can get information on trends and procedures, trends in different ways diseases are being diagnosed. A very rich source of information. And then we have, as I mentioned, your genome data, where you're going to have thousands of data points on a couple individuals. It's the complete opposite of what we have in the EHR, where we have thousands of individuals with a couple data points spread throughout. We have the wearable devices, environmental data, social determinants of health, and quality of life information. So what we're interested in doing is how do we pull all this information together to create sort of a tapestry of resources? And I think that's a really interesting way to think about it. And there was an article in JAMA in 2014 that talked about merging and fusing all this data together to create a tapestry of healthcare resources. And merging these data together are very complex, but it's possible to do. And people have been doing it. If you look in the literature, people have been connecting EHRs with environmental data, social determinants of health, with claims data. People have been connecting these data all in different buckets, for quite some time. But pulling it all together, pulling all of these pieces together, is very rare. You don't see it very often, but I think it's where we're going. And again, if you think about our wheel of sort of health and well-being and how all these pieces fit together, you can see the importance of including some of these other pieces of information. So I wanted to talk to you a little bit about the focus of the research we do in my lab. And we have three main areas of focus. One is quality analytics. So all of our research focuses on electronic healthcare records, and then we pull in these other sources of data. But we start with clinical analytics, and that is a great way to get your faculty position, get promoted, get your students going. We basically create this resource where we can have students, postdocs, junior faculty come in and ask these clinical questions, and we have the data to back it up. We can have a clinician come in and say, I had a patient come in the other day, and they had, a Vietnamese woman, 55 years old, and her potassium level was here. What's the average potassium level for a Vietnamese woman? Can you look that up? We can. We can look it up in the EHRs, because most of the data, when you look at randomized control trials, most of the benchmarks, they're from, your white male, 55 years old, higher social economic status. It's not representative of these other diverse populations. So by looking at clinical analytics, we can answer these questions for some of the, for people coming in. We have medical students who come in and, they might have a very distinct research question that they want to do. We can help them pull that data to answer some of these questions. It's a great tool to sort of generate information, clinical analytics, to try and develop evidence to help guide both practice and improve healthcare. Our second focus is on quality of healthcare delivery and guideline adherence. And so I'll give you some examples of those, of what we've been doing. And finally, we look at machine learning in healthcare and how we merge all this information together to do some predictive modeling. But to start, we do this data fusion. And I wanted to give you two examples of how we're pulling all this data together. Two of my main project focuses are prostate cancer, which we've now expanded to breast and colon, and surgical pain, which I will show you too. So what we do, as I mentioned, we start with electronic medical records. And for our cancer database, what we do is we identify any patient in our EHRs who has a cancer diagnosis for prostate cancer using ICD-9 codes. We take all our patients and we send their names, social security numbers, et cetera, to the cancer registry, to our state cancer registry, to get a match for our patients in the cancer registry. And we do that because the cancer registry contains curated data. They have all survival information on our patients. We can identify if patients have had treatment outside of our university. We get metastatic recurrence disease, all of this information that's collected through the central registry. In addition, we have mapped our claims database for the state of California, which is the OSHPA data, to the cancer registry. So by this three-way linkage, we now know for all of our patients that come through Stanford with a cancer diagnosis, we know how much they've utilized any hospital services, ED services, or ambulatory services throughout the state of California. And this is really important for us because at Stanford, we can have a patient come in they'll get their treatment, they'll go back to Fresno, and we'll never see them again. So by doing these linkages, we now know, maybe they go back to Fresno and they go back to the ED 5 times from a surgical infection, or maybe they have other types of complications. So we can now track this information and get it utilization. We also link our EHRs, so we know the zip code, as I mentioned, of every patient. So we're linking that to geocode data where we can get information on pollutants, we get information on the environmental factors, we get like crime in the area, if that's something that's going to be of interest, etc. We are starting to link to wearable devices, so we're starting to pull in that information. So of course we have a lot of clinical trials going on in our center, so we're able to identify those patients who are involved in a clinical trial and capture that information from through the electronic medical records. We are mining the records to identify social determinants of health. Interestingly, we were looking one time at discharge medications for knee replacement surgery, and we had a whole group of patients who are not getting any pain medications following their knee replacement surgery, and we're like, this isn't right, there has to be something going on. Well, when we went through the records and started mining the records, we identified that there was a particular clinic in our office who gave their discharge medications in the pre-op visit because the patients had a problem with access, with transportation. So they would give them their pre-op visits prior to surgery so they wouldn't have to make the extra trip to the pharmacy after their operation to get the medication. So interesting how they can take into account transportation issues or something like that and be able to address that. We also capture surveys, and so this has been a really great resource that we've just tapped into. So at our hospital, as I'm sure here at Michigan, we collect information on promise surveys, quality of life. We have validated surveys, for example, for treatment side effects following prostatectomy. And so all this information is captured and pulled into the electronic healthcare records. And we've been able to link that to our cohort of study so we can start looking at some of these quality of life surveys. Understanding when we see a patient whose quality of life is decreasing, what are the associated outcomes with that patient? Are they having higher rates of unplanned visits? Are they having higher rates of other resource utilization that we can identify and then eventually predict? So we can identify these patients who might need more resources. And then finally, we're pulling in the genetic information. So again, because we've done a lot of these clinical trials at Stanford, we do have information on the genetics that have been taken from other studies that we can pull in through the EHRs. And so this is another big piece of information that we're excited to look at. As I said, my second project we're working on is surgical pain. We've done sort of a similar data fusion for surgical pain. Instead of linking to the cancer registry, we link to the state registry for controlled substance use. So that's able to give us any prescription for a controlled substance our patients had over the past 7 years. So that can give us some good information when we start thinking about identifying patients who might be at high risk for opioid dependence, identifying patients who might need different levels of pain medication because they're on prior pain medications. And so that's something we're really excited about incorporating into our data set and using. And so we spend a lot of time merging these data sets together. And then the next piece we do is a lot of text processing. Now, I'm not going to spend a lot of time on this. I talked about this last time I was here. But what we do for our text processing is we try and use all information available in the EHRs, in these other data sources, including the text information. So we have a lot of experts on our study team. We have nurses who help us annotate records. We have medical students who annotate records. And whatever term or concept we're interested in, we develop dictionaries that are validated, that are generated by these usually 2 or 3 different experts in the field. We do some processing on that. So we take the information in, we map any terms to ontologies. So for example, when we're looking for acetaminophen, we don't want to look for every trade name drug, which there's over 1,800 different trade names for acetaminophen. We want to look for acetaminophen and have the ontology show us all of those associated synonyms and trade names with that term. So we map to ontologies to grab this hierarchical information. We negate information. And negation is a very important piece in healthcare data, and probably healthcare is one of the only one of the only domains where you really need to negate this information. We want to know whether a patient had or did not have a particular drug. We want to know whether they have or do not have a particular symptom. And so you need to pay special attention when using this text data to negation and how we can take that information and note if it's really an affirmed instance or a negated instance of that information. And then we pull this information out and we put it into a matrix where we look at these terms of interest on the columns, patients on the rows, and then time over time, so we can look at them longitudinally. So let me walk you through a few examples that we have done. For clinical analytics, you know, one of the questions that came to us from our clinician was, you know, a patient comes to me, so for prostate cancer, survival is very high. I think 5-year survival is above 89%. So the patients are really interested in treatment-related side effects, which include urinary incontinence, erectile dysfunction, bowel dysfunction. So the clinician came to me and said, you know, I had a patient and they said, you know, they can live with a diaper, but they can't live with erectile dysfunction. And they want to know what's the best treatment for them. What is their probability of having urinary incontinence with treatment A, with like a prostatectomy versus radiation? And we don't have any evidence to guide that decision right now. And the reason why there's no evidence is because these are patient-centered outcomes. They're not routinely collected. They're subjective. And so we just don't have evidence to guide that. So we said, that is easy. We can totally capture that in our electronic healthcare records. Well, urinary incontinence is not something easy to capture. And there are so many different ways you can say it. It's very subjective. We've given it to our nurse. We've given her the same records different times, and she changes her opinion about what really constitutes urinary incontinence in the note versus what doesn't. So it's a very interesting concept to look at. But what we did find, importantly, was, well, first we went through and we said, oh, well, we'll just look and see, you know, how many patients having prostatectomy are coded with an ICD-9 code. We had 4. 4 out of 5,000 had an ICD-9 code for urinary incontinence. Well, that's not true. That cannot be the case. So we then went and looked in the clinical notes and see how often is this documented. We got much better results. So we had, of a total of 5,000 notes, we had about 1,500 who actually looked at urinary incontinence and documented it. And of that, we found that about 30% had an affirmed mention of urinary incontinence. So this was great. We were really happy with this. But then, of course, the clinician says, well, you know, if the nurse isn't so sure about this, how does this match with some of the patient-centered, with some of the surveys that the patient are taking? So we then took our algorithms that we've used to extract this information from text, and we compared it with the EPIC 26 patient survey, where the patient is taking the survey saying whether they have urinary incontinence or not, over a series of several questions. And we were very pleased to find that we had very high concordance between what the clinician was reporting and what the patient was reporting over time for urinary incontinence. So that means that we can then take our algorithm and look across different treatment strategies. So we can get some evidence on what strategies are more associated, what strategies have higher risk of urinary incontinence compared to other ones. And so what we found, so this is looking over time, pink line, sorry, UI, that should be baseline, their baseline rate. So we had about 16% of our population had a baseline rate of urinary incontinence. And then we could look over time. So, you know, you see that surgery has higher rates of urinary incontinence compared to radiation. And that's something that they've looked at in smaller surveys. It's nice to see this with real world data. And so this is evidence we can generate regarding these outcomes that we can share with our providers and think about how we can start bringing this into the point of care. More importantly, when we do some risk algorithms, we find that the most important risk factor for having urinary incontinence 12 months post-treatment was having pre-treatment urinary incontinence. So this is evidence we can generate to help guide that conversation between the clinician and the patient. And it really shows how we're pulling information from the patient surveys, we're pulling information from the clinical notes, We've tried to pull the information from the claims data. It wasn't there, but we're pulling information from all these different resources to generate this data to help guide these discussions between the patient and the clinician. We've done the same looking at a different topic. So let's look at the US opioid epidemic, right? So as we know, in the US, we're currently in a severe crisis for the opioid epidemic. Since 2000, there's been a significant increase in opioid-related deaths. I believe this year they said there were more deaths from opioid-related causes than car accidents. So it's a huge problem in the U.S. So, and the postulated causes were, in the beginning of the 1990s, of course, they said that we were under-treating pain. So clinicians were really encouraged to prescribe more opioids, to really treat pain, and make sure that the patient was satisfied with their pain treatment. So we first turned to claims data to look, what is going on in the opioid epidemic across the entire US population. And of course, not surprisingly, we found that everything was increasing. We looked at opioid dependence, opioid abuse, and these are inpatient admissions, and dependence, opioid use, and there was another one, opioid poisoning. But what we found, interestingly, was when we were able to break it down by prescription opioids versus heroin, fentanyl, and some other ones, we found that actually prescription opioids, so admissions related to prescription opioids started decreasing in 2010, which was really interesting. However, if you look at heroin, fentanyl, they're skyrocketing. So it seems that we see a shift. So prescription opioids are being less attributed to some of these opioid-related hospitalizations, but heroin's just taking the place. The other thing we saw that was really interesting when you look between 1997 and 2014, we see that previously these opioid-related admissions were seen in young white males, mainly in the Northeast. In 2014, it's ubiquitous. It's across all populations. We see increases. We see about the same between males and females. We see even the elderly population over 65 having an increase in opioid-related admissions. So really going across all populations. And this is concurrent with what the CDC has reported, looking at fentanyl deaths over the past 3 years, 500% increase in fentanyl deaths. So really important problem we have right now in the healthcare system. A lot of people looking at how we can change sort of opioid prescribing patterns and how we can, sort of curb this epidemic. So we wanted to see what was going on in our institute. So again, using our EHRs, we started looking at different ways of, or different prescribing patterns for opioids for postoperative pain. And what we had, again, we had a clinician come to us and say, most of my patients coming who are seeking pain medications have some other type of depression or some other type of mental health illness. And so the question was, the most common antidepressant in the US is the SSRI, so the selective serotonin reuptake inhibitors. And SSRIs are a CYP2D6 inhibitor. Well, the most common opioid is a prodrug opioid, which is codeine, oxycodone, and hydrocodone. Well, those need CYP2D6 in order to be metabolized into their active form. And so the question was, if my patient's taking SSRIs and we're giving them these codeine, how is their pain management? Are they seeking more opioids because they're not having their pain managed? And so that was a really interesting question that we wanted to dig into and look at. So co-prescribing patterns of SSRIs and opioids. And what we found in Stanford was that about 25% of our patients were on an antidepressant, SSRI, or were on an antidepressant, and of those 25%, 9% were on an SSRI. Of that 9% of those patients, over 50 of them were receiving a prodrug opioid. meaning that one, the opioid was probably not being metabolized sufficiently into active format. Two, they probably weren't getting active pain management. And three, they would probably have to seek more pain medication because they weren't adequately being treated. And we did indeed, when we looked at some association studies, we found that patients on these combined SSRI prodrug opioids had higher pain at discharge, and they came back more often for pain, or they had higher pain at their follow-up postoperative visit. So real-world evidence looking at some of these questions that clinicians are bringing to us. And so we were very interested in some of these scenarios. But then talking about this with colleagues from the genetics department, they said, well, if you really want to look at this, you need to get a panel of CYP2D6 and cytochrome P450 cycle, because that's really where you have over metabolizers and under metabolizers that you would have of some of these drugs. And so now we're looking at two things. We're looking at, one, can we look at a panel of patients who have a polymorphism on the CYP2D6 gene and see how they respond to pain medication? How do they respond, after surgery? What is their pain trajectories? And the second thing is, can we take this information and develop some clinical decision support so that a provider knows if their patient is on an SSRI, they probably shouldn't be given a prodrug opioid. There's other types of opioids they can be given. And so just guiding different treatment options is a path that we're going to take. So let's just give you an example of some of the clinical questions we ask. We also are interested in looking in quality of healthcare delivery and guideline adherence. And so one of the things we've been interested in looking in is screening guidelines. So again, I'm going to give you my example with prostate cancer. But in 2012, the U.S. Preventative Task Force recommended against PSA screening, which is the screening for prostate cancer for all patients of any age. And so there was a lot of controversy about this recommendation, certainly from the urological community. And so we wanted to know in our healthcare system, how did people change their screening behavior? How did clinicians change their screening behavior following this guideline recommendation? And what we found, so we did a difference in difference analysis. So we look at the crude rates here, but then we did a difference in difference analysis to take into account secular trends that might be going on with PSA screening rates. So we compared the PSA rates with cholesterol screening and TSH screening, so for thyroid screening. And what we found overall was that we found the screening rates dropped in every age group. But in particular, we saw the highest drop in patients over 75. And that makes sense because these patients over 75, they're more likely to die from other causes than they are prostate cancer. So what was happening is people were being screened for prostate cancer. They would have a small cancer detected. They would undergo treatment that was likely unnecessary because they were most likely not going to die from prostate cancer, but of other causes. So it was interesting that we could see a drop in screening rates across all age groups. And we also found that we saw a decrease in early stage diagnosis for prostate cancer. So we saw less prostate cancers being diagnosed in their very early low-grade stages. So, and that was the whole point of changing these guidelines screening. So, what we take from this study is, I think the study highlights the potential for guidelines to increase the efficient and effective use of medical care and potentially reduce overtreatment, right? So the whole reason to change guidelines was due to this overtreatment. And we saw that, our clinicians did a good job at responding. However, when we break it down, looking at primary care versus oncology versus urology, the one group that did not change their screening practices was oncology. And that probably makes sense because if they're coming into the oncology department, there's probably a good reason that they're there. They might have other risk factors, and so we didn't see a change in that pattern. But when we think about this, we can also think about screening for, thinking about ways we can develop evidence to screen for cancers. So if we're not going to use PSA for screening for the general population, can we identify populations who are at high risk for disease that need to have higher rates, higher screening patterns? And so one of the things we're really interested in looking at is germline mutations. So there's been a lot of media recently on germline mutations in prostate cancer. So in particular, BRCA1, BRCA2, germline mutations have been associated with increased risk of treatment-resistant prostate cancer. And so we have a group of folks at Stanford who are trying to phenotype, so people who've been screened and have this polymorphism, can we phenotype these patients in our electronic system so we can identify these patients likely have a polymorphism without actually doing the test, so trying to predict who might have this polymorphism, so that we can identify patients who might need more screening compared to others. So this is something we're just exploring right now, but it shows how we can combine the genetic information with our EHRs to identify these phenotypes, to try and identify pockets of patients who might need more screening, higher screening rates, higher screening, different screening guidelines. So, about time. I want to wrap up here in about 5 minutes. So I'll tell you one more guideline information that we've been looking at, and that is with the opioid epidemic. So again, going back to our surgery pain database, we've had a lot of guideline changes because of the opioid epidemic. And this is a pamphlet the CDC put out that the Surgeon General distributed in end of 2016. And they said that, patients should not be getting, or for patients who get more than 70 morphine equivalents per day, you must increase their number of follow-ups after discharge. We should avoid giving any patient over 90 morphine equivalents per day. And we should avoid giving more than 7-day prescriptions of opioids at any given time. At the same time, we have CVS, our pharmacy company, who has just released a policy that beginning February 1st of this year, they will no longer be prescribing more than 7 days, they will no longer be providing more than a 7-day supply of opioids, even for postoperative pain care. So where is this evidence coming from? And can we think about ways that we can use the evidence we have in our electronic healthcare records, evidence that we have that we've been gathering from all of these patients to generate evidence to kind of guide these policies? I mean, for me, when I look at what we've seen from people being discharged after surgery, 7 days is great for a lot of people, but that's definitely not going to be sufficient for somebody undergoing a major operating room procedure. And so can we generate evidence that can help guide these policies? And so we've been looking into our system to look at, how much morphine equivalents do our patients get per day? What's the variation? How long after the discharge are they getting these prescriptions for? And so we found some really interesting information. First, we found that over 20% of our patients, and these are two different, this is, the first pie chart is our patients at Stanford University. The second pie chart are patients in the VA healthcare system. So we wanted to compare the two different systems to see, the algorithms we're developing, can they be generalizable across populations? So the first thing we found was about 20% of patients go home with opioids alone after a surgery. Guidelines suggest that, you should be getting some type of multimodal therapy, which would be an opioid plus an acetaminophen plus an NSAID. And we found that patients who have these multimodal therapies, they have better pain outcomes. So we see a large number of our patients go home with opioids alone. Then the graph is looking at the average daily morphine equivalents we have for a patient following their procedure. And we see we have a large proportion of our patients who receive over 90 milligrams of morphine equivalents per day. So I think we're starting to gather this evidence, we're starting to generate these data so we can start looking at these health policies, these guidelines, these recommendations, and provide evidence to help steer and guide them and give meaningful information to help them refine these policies. Okay, I'm going to skip this one because I want to wrap up. We also do some clustering, some machine learning, trying to identify patients who would be, as I mentioned, we do classification and clustering algorithms to see if we can identify patients, staging based on pathology reports. I'm not going to go into this in detail because we're running short on time, but I would be happy to talk with you about this after the lecture. I want to wrap up, and I hope that I showed you today that we're really trying to pull together all different types of information. We're trying to go across these different silos of research, meaning genetics, health services research, social determinants of health, claims data. We're trying to pull them all together so we can get a bigger picture, a better picture of actually an episode of care from a patient perspective, from a patient view. So, you know, I think we've been thinking really hard about how you can merge this data together to develop sort of this tapestry of healthcare information. Each data set you use and each time you combine these data, they require different tools. You can ask different questions. Each one of them holds their unique set of use, questions, and methods that go along with them. We're trying to generate evidence to help guide both clinicians in their decision-making as well as policymakers when they're trying to develop guidelines and recommendations for best care. We're trying to utilize all data available. You know, we've been thinking really hard about standardization of this information. How do you systemize this information? I think it's I've had a great conversations today with the folks from the Learning Healthcare System group, thinking about how do you take it the next step? You know, does your research end once you get that publication, or does it end once you can bring it back into the healthcare system? Can you bring it back into the point of care where you're really changing both the care that patients are receiving, the quality of care, and educating the entire system based on evidence that we already have, that we've already generated? And with that, I want to say, you know, this is really the efforts of a multidisciplinary team. I have created very diverse teams that have just been really great to work with. We have our clinicians are just as involved as our methodologists. We've developed this infrastructure, so we have a lot of students that come in and work with us very seamlessly. As I said, we have, you know, students who just started this quarter, they get their data sets to work with within a couple weeks. And that's really beneficial to the medical students, to the postdoctoral students, to our graduate students. And we try and tackle a problem from both the methodological standpoint and the clinical standpoint. So we couple people on these projects, but there's always like a methodological paper that comes out of these projects, as well as clinical papers that come out of these projects. And even the methodological paper, I mean, we can have many, many different clinical papers that spin off the same methodology. So it's been really important for me to develop a system that can seamlessly leverage this data we've been collecting, use the data that we have to try and inform healthcare and inform the quality of care we do. And so I will close with that, and just a few minutes for questions. I want to just thank my my funders, NCI, ARC, and AstraZeneca for this work. So thank you very much.
Thanks, Tina. I had a quick comment and then a question.
Sure.
Comment was that we also, as part of music, are looking at predicting patient-reported outcomes after surgery. Mm-hmm. And although we found baseline urinary function is one of the more important variables, we also found it was not predictable. Like our area to the curve after incorporating every single possible variable from your biopsy with over like a couple thousand patients was like in the 0.6 range. So just something interesting. Yeah. And one way in which it is going to change practice is that they're actually thinking of routinely referring all patients at 1 month who have incontinence for pelvic rehabilitation therapy and making that a standard across the state. So that's just one of those things.
Interesting.
The question I had was, one advantage EMRs have is that we actually have address level data.
Right.
And so as part of one of the projects I'm doing, we're geocoding addresses. Have you guys looked at geocoding addresses down to like latitude, longitude?
Oh, we have, well, so my group hasn't, but we have some people in our department who are looking at, and they're the ones who are looking at grocery stores within a certain distance from their house. And you know, what's transportation? How far do they have to walk to any type of public transportation? And that information is really exciting. And there's really a lot of that information that's available that's not being used right now. But I think, yeah, when you can go down to the address level, the zip code level, you get some of this really interesting information that can be useful.
Going forward, is this something where you're always going to have people extract the data to do this, or is it clinicians need to just write things in a standardized? I mean, as a pathologist, we have to template the stage every time. So I can code those. I mean, you don't need anything fancy to code the stage.
Exactly. Well, so you don't need anything fancy to code the stage, but somebody has to look at the report, right? And so we're not trying to, so when we're looking at stage for documentation, we're trying to facilitate the clinician's amount of effort they do. So if we can highlight the key words that are distinguishing between stage 2, stage 3, and stage 4, and highlight those words in the pathology report, we're helping the clinician do that in a more accurate way. We can then predict the stage and then see how much variation, see how accurate we are compared to what the clinician's saying. We don't want to ever replace the clinician. We want to help guide them, help highlight the information that they need to make those decisions. As far as templates now, for example, prostate cancer with urinary incontinence or erectile dysfunction, it is one of the most common side effects. So it is something that you could see being moved to a structured data field, smart text in the EMRs, but we need to first identify what information is being captured, how is it being captured, what amount of detail is being captured, and then think about is there a way we can standardize that? Do the clinicians want it standardized? A lot of them like to type their long reports. But thinking about that, you first need to have the data and see what it is, what's being captured, and where we want it to go.
So you mentioned the anecdote of a Vietnamese woman earlier, and I was wondering if there are ethical discussions amongst you and your collaborators on using race as a criteria.
Well, it's interesting. We do talk about that a lot, and so in the Bay Area, of course, we have one of the biggest Asian populations outside of Asia, and so we like to break those down into meaningful subpopulations. But when you look at the benchmarks, if you look at probably 90% of the benchmarks we use in medicine today, they're from clinical trials that were based on your 55-year-old white male. And so how relevant is that to a Vietnamese woman? How relevant is that to your 25-year-old Hispanic man? Nobody's been, I mean, people are starting to look at that, but we don't have that granular population level data. It hasn't been collected. Well, it's been collected, it just hasn't been produced in benchmarking purposes. So I think there's a lot of information that can still be extracted, just characterizing these different populations and different benchmarks of their baseline medical information.
Very nice work and very nice study.
Thank you.
One of the things that you mentioned was the bias that's introduced based upon information availability through an EMR.
Right.
Have you given thought as to what needs to be done to overcome that limitation and that bias?
That is, that is an important question because it is a huge bias we have. Now here at Michigan, you also have your primary care facilities feeding into the EHR, which we don't have at Stanford. We have very limited primary care. But that's something we need to overcome. And how do we start pulling information? And again, when I put that picture up of the person surrounded by all that information, our first thing is to say, here's the patient. And we need to start thinking about not here's the patient, here's the person, right? How do we start collecting this data before they get sick? And one of the ways people are looking to do this is through wearable devices. They're not in the hospital, they're not being seen for any crisis. Can we start integrating that information into the healthcare record? How do we integrate it? How do we use that information? But getting more information on daily activity from healthy individuals will help, broaden the way we can look at that information. But it's a huge challenge. But, you know, for example, Google's doing their Million Healthy Patients project. That's going to be a huge piece of information that I hope we can all leverage and take into account when we're starting to think about, you know, healthy behaviors and risk, you know, risk factors for diseases.
Yeah, thanks very much, Tina. That was very, very interesting. And I particularly liked the slide you had at the beginning where you showed sort of the different pieces of data.
Mm-hmm.
And I think the approach you're taking makes a lot of sense. But I think there's a really important set of missing data. And that actually gets to your point about how do we actually incorporate these things into systems. We have very little system data. And the kind of system data we have is not very useful. You know, how many admissions does a hospital have? You know,
right.
We can't even say often how many providers does a hospital have, much less what do they do, how do they do it, what are their attitudes and beliefs about things.
Yeah.
And I honestly think that is going to emerge more. It already exists as a known gap, but it's going to be even more of a gap as we have increasing amounts of data from the patient side of things, from the environmental and social side of things, but nothing about the systems.
Right.
And so I think the way you're approaching this makes a ton of sense, but until we have some of those data and have them reliably and in data streams that make them possible to capture, it's going to be very difficult to take that next step.
Right. And when you talk about systems data, are you talking about the way the data is captured? Are you talking about the way the data is utilized? Are you talking about the guidelines, the information, how that information is distributed across clinicians? The whole, the system as a whole. Yeah, yeah. I agree. I agree. And that's going to be a big piece of how we interpret this data, how we predict data. I mean, you can't start predicting this information with any accuracy without taking that into account. I completely agree. Oh.
So you please pass some of the reproducibility stuff.
Sorry. Yes, I did.
Okay. One challenge where I would like your input. In pharmacogenomics in particular.
Yep.
It will sometimes be the case that in a controlled randomized trial, you will not see an effect that you see in the wild.
Right.
And one possible source of this is the quality of the care the system is delivering in a clinical trial. In a clinical trial, everyone is getting optimal care, whereas this may not be the case in the real world. But that is a very delicate issue to incorporate.
Right. Right.
Do you have any experience bridging that in your disability or any other?
Well, you know, let me just show you one slide that I breezed past because we ran out of time. So this was a clinical trial that was, over here, this one by Jennifer Ha was just published in JAMA Surgery. So they did a clinical trial looking at the inclusion of gabapentin for postoperative pain and its association with pain and opioid cessation. And so this was, you know, a 6-year trial. I think it had 400 patients, millions of dollars. So Jennifer Ha is working with our team, and I said, you know what, I bet you we can reproduce your study in our EHRs in 2 weeks' time. And we did, and we found, using our EHR system, so we had 4,000 patients, looked at the exact, so we couldn't match on dosing, but they didn't have detailed information on their dosing. But we looked at patients undergoing the same surgeries. We looked at them, who got the gabapentin versus not, and we compared their pain outcomes and their opioid cessation. We found the exact same results that they did in the clinical trial, and we were able to do this in a matter of weeks. And so that's one way that we can start thinking about how do we use this information from a clinical trial in the real world setting. Here we could show, you know, this very controlled trial. We could see the same effects in our real world setting. That's one way. The other way is, you know, we're starting to look at pragmatic clinical trials, which is another way to think about it. So can we identify retrospectively these cohorts of patients who are getting drugs versus not getting drugs? And by doing the pragmatic trials, you know, we're not restrained to these inclusion-exclusion criteria. So we're going to have wider, you know, standard errors. We're going to have wider confidence bands, but we can still look at some of the same questions. finally, what we try and do is we try and take the models we develop at Stanford, and we're trying to implement them at other places. So I showed briefly some data with the VA system. So we develop our models at Stanford, and then we try and look at the generalizability in the VA system. Whether the VA is a generalizable population is another, is another question. But really, reproducibility is a huge aspect that we need to face. And we should always be thinking when we're developing these models, you know, how are they going to fare somewhere else? How can somebody pick up this work we've done and implement it in their system? Yes.
Thank you for bringing that up. It's important. There's just a couple little things we ran into in our randomized control trial that we ran
Yeah.
this year ourselves. Coming out in the American Psychiatric Association. 30 or so sites, half of them were academic sites. Half of them were, you know, community hospitals. There's one difference. One thing that, you know, in 2020's hindsight, and this was relatively small, it was 1,432 subjects.
Okay.
But, you know, one thing that I think is important to put into the statistical model is sometimes what happens is that the people in the treatment arm, we had treatment versus treatment as usual. And in the treatment arm, when people get better, they don't show back up to the trial. And that drops your N.
Yeah.
And you have to have a correction factor for that. When you have relatively small numbers and 135 people don't show up, I mean, it can really change things. So, I mean, there are all kinds of little things like that you know, that are affecting it. And, you know, frankly, what we need, and you probably said it already, is, you know, more creative trials. That equals one trials and all the Bayesian trials and all the rest of the stuff, so we're not stuck with the RCT.
Yeah, exactly.
Yeah. More questions?
Yeah. So like the dental data, these other types of data. So we were talking about that last night.
Talking about this last night. This plays a role in the opioid crisis.
Right.
Go ahead. Repeat the question.
So it's a great question, and we so far we haven't been able to pull in the dental data, but I think it's a huge piece of the opioid crisis, as we were saying, and it really needs to be captured. When we think about that patient, it's not just their inpatient and ED visits we need to think about. It's their entire, you know, life interactions, and dental is a huge piece of that. We were talking about the opioid epidemic.
What we were talking about was, you know, some patient comes in with a toothache, the doctor's too busy. Here, take these pills and come back and see me in a couple weeks. And evidently, this is standard of care in some dental practices across the country. Yeah. And if it's 6 weeks, if it's 6 days to addiction, you got a problem.
Right. One of the things we've done to try and address this is by looking in the VA system, because the VA system is all comprehensive. And so you have that information in the VA system. Well, VA is very difficult to use. It's very difficult to get access to. But if you can get in there, you can look at some of this information because it's an all comprehensive system. You do have the dental information in there also, which would include like medications and things like that. So that's one way to look at that in different populations.
At MIDAS, you know, our Michigan Institute for Data Sciences, we have a data set from Delta Dental that was provided to them. And actually what they were looking for was us to do kind of anomaly detection, because there's a lot of billing fraud. But I think the drug records are there. So if anybody is interested in that data set, let me know and we'll get you access to it, okay?
Yeah. Yes. Right. You know, I had a conversation about that today, and I'm forgetting who it was, but what do you do when a patient says they don't want to share their data? How do you deal with that from a systems level? How do you pull their information from the EHRs that's just shared with, or not shared, but provided to researchers? And that's, you know, that's a challenge. And I don't know how we're going to deal with that when you have some patients who say, I don't want my data used for research. Pull me out of the system.
Well, we went with the, we went after learning from Vanderbilt, we went with the opt-out.
Yeah.
So you're coming into a research hospital.
You can opt out.
You can opt out, and actually, what the numbers are relatively small,
Right,
3 or 4% opt
Yeah.
out. So in keeping the form simplistic and understandable and high level and transparent is absolutely key in this game.
From a data perspective, if you're thinking about, you said fear of using big data. When you look at the data, so I showed, the data is very sparse across all these different pieces of information. When you consolidate that down, it's really not that big. For our entire healthcare system, if we, consolidate all the data from where we have data points for our EHRs, it's about, 3 terabytes max. So it's not huge. It's not a huge amount of data. It's definitely something that you can work with, you can manage. We can process all our data within, a reasonable time period. And so I don't think it's challenging, but I don't think there's a way to get around it. I think big data is what we have, and it's where we're going. And so that's just something that we're going to have to learn and develop tools that we can share to use it and use it correctly, thinking about the right methodology.
Oh, there's one more.
Yeah. Thank you. Right. And I think that's sort of the system question, right? How do you bring this into the system in an automated fashion? I mean, there's always the need for research because we need to identify what are the problems with the data, what's the quality of the data, what's the question we're looking at. And then once we refine that and we see, what are the caveats with the data? How do we overcome this? Okay, here's the information we want. Then how do we streamline it back to the point of care? How do we integrate it into the system so that we're not like reinventing the wheel every time we want to look at this? Or so that it's not only available for a certain set of providers, but for every provider. And so I think that's really the system levels approach where we need to have this full cycle of integration of evidence around where we're generating the research gets brought back to the point of care, we create more research, and that's your cycle.
That sounds like the last word, as they would say on TV. Thanks so much. It's delightful to have you back. And
Thank you so much. Thank you.